Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. Today we are going to be talking about clinical EKG interpretations. This is based on my book on clinical EKG interpretation and patient management. You can check this book on Amazon.com. Here is the table of contents, and please do watch the first presentation on introduction and electrical access. In this presentation, we are going to cover conduction disturbances and bundle branch blocks. So let us begin. In this presentation, we are going to be covering various degrees of AV block, high-grade AV block, complete heart block, and pre-excitation. Later on, we'll be talking about chapter 4, which includes various types of bundle branch blocks. So during the first half of the presentation, we are going to be talking about electrical conduction disturbances involving the AV node. And during the second half of the presentation, we are going to talk about conduction disturbances below the bundle of His. Majority of these conduction disturbances do signify an underlying heart disease, such as ischemic heart disease, hypertension, valvular heart disease, cardiac surgery, congenital heart diseases, and infiltrative cardiomyopathies. So we do need to pay significance to each one of these conduction disturbances and watch for any progression of these disturbances to a more serious condition. This presentation is going to be more interactive. First, I'm going to present to you an electrocardiogram or a rhythm strip and give you a chance to interpret that, and then I'll come back and give my explanation for those rhythm strips or electrocardiograms. So let us continue. What is your diagnosis and what are your differential diagnoses? Take a moment, pause here, write down your diagnosis and differential diagnosis, and then resume the video presentation. Here we see a regular what appears to be a sinus rhythm. Each one of them has a P wave, a QRS complex, and a T wave. The most significant finding in this rhythm strip is the prolongation of the PR interval, which is approximately occupying 6 small boxes, which means the PR interval is 240 milliseconds. The upper limit of the PR interval is 200 milliseconds, and this is definitely much longer than that, and this is an example of a first degree AV block. Whenever we see first degree AV block, we rarely ever pay much significance to that, but as a cardiologist, it does signal to me that there is some underlying disturbance in the electrical system of the heart. And this becomes more important in patients with chronic heart failure, dilated cardiomyopathies, where optimal cardiac function is based on the timing of the atrial and ventricular contractions. And that's why we very often pay attention to the PR interval when we are trying to optimize the cardiac output in patients who have dual chambers or CRT. Take a moment and write down your findings as to what you're seeing. Think about the differential diagnosis. Here we see what appears to be a sinus rhythm, and all of a sudden there is a P wave with a missing QRS complex. There are a few other things which are pretty clear on this rhythm strip, namely the PR intervals are getting progressively longer before a P wave is dropped. This is an example of a Wenckebach type second degree AV block. There are a lot of features that we need to recognize in diagnosing Wenckebach, because as soon as we see it from a distance, we should be able to think about this as one of the presentations. First of all, grouping of heartbeats with pauses. That should signal your mind you may be dealing with Wenckebach. This may also be a premature atrial beat that is non-conducted. How do we make the differentiation between a premature atrial beat versus a dropped P in a sinus rhythm? There are a lot of important features in Wenckebach second degree AV block Mobitz type 1. If you notice, the P intervals are constant. If the P intervals are constant, that means we are not dealing with a blocked premature atrial beat. So this is part of the sinus rhythm. The second thing that you'll notice is the RR intervals are getting shorter. PR intervals are getting longer and longer before a P wave drops the QRS complex. It generally does not cause any significant hemodynamic changes in patients. This is frequently seen in patients with inferior myocardial infarction. It is a self-limiting arrhythmia which resolves with time, and rarely does this progress to second degree AB block type 2 or high grade AB block. Next, what is your diagnosis? You already have a little tip here. Is this first degree AV block? Is this second degree AV block type 1 or type 2? Is this high grade AV block, or is this complete AV block? Let's look at the differential diagnosis here. First degree AV block, the PR interval is 200 milliseconds, so it is not first degree AV block. Is this second degree AV block? Actually, it is not second degree AV block type 1 because we have two P waves dropped here after two normal heartbeats. And the PR intervals are constant, so it is not a Wenckebach. Is this a second degree AV block type 2? Possibly, yes. This is a second degree AV block type 2 because the PR intervals are constant and there are two P waves which are dropped, then the rhythm resumes. Is this high grade AV block? If you record a longer strip and if multiple P waves are dropped, you may be dealing with a high grade AV block. Now finally, is this complete AV block? In complete AV block, there is total dissociation between the atrial and the ventricular activity. There is no correlation between the P waves and the QRS complexes. The atria are beating on their own, the ventricles are beating on their own, albeit at a slower rate. So this is not an example of a complete AV block. So this is a second degree AV block type 2. Next, what is your diagnosis? Take a moment, write down your findings, not just one diagnosis. We want you to write down everything. For cardiology boards, you have to say the rate, the rhythm, and the arrhythmia you see, along with any ischemic changes or secondary STT changes. All these things have to be noted. So let us start with the anatomy of this rhythm strip. First of all, we have a bradycardia here. We have a narrow QRS bradycardia. Assuming this is the RR intervals are not exactly constant, but assuming this is a narrow QRS complex which is regular, you see the rate is very slow. So this is a severe bradycardia with a narrow QRS complex. Now let's get to the atrial activity. Here, the most important thing we want to do is we want to get the atrial rate to start with and then see if the atrial contractions match with the ventricular contractions. If they don't, look for AV dissociation. And if you see AV dissociation and if none of these P waves are conducted, then we could be dealing with the complete heart block. This P wave comes here, we have the next P wave here, this P wave is here, this P wave is here, this P wave is here, and the P waves are marching on their own. There is really no correlation between the P and the QRS complexes as the PR intervals are grossly variable from beat to beat. And if this is a high-grade AV block, you expect some of the P waves to be conducted producing what you call as a fusion beat. So this is not a first degree AV block. So this is not even second degree AV block. And this is not even type 2 AV block. Is this high grade AV block? Not really, because we don't see a clear correlation between the atrial and the ventricular activity. And this is an example of a complete heart block with an atrial rate which is approximately like 80, and the ventricular rate is much slower than that. There is no relationship between the atrial activity and the ventricular activity, which underscores AV dissociation. This is most likely junctional rhythm because it is a narrow QRS complex. If the QRS complexes were wide, then you may be dealing with a idioventricular rhythm in a patient with the complete heart block. Let's move on to the next slide. Okay, what are we seeing here? Here we have a rhythm strip. If you look at, the ventricular rate is slower. The QRS complexes are narrow, and the morphology of the QRS complexes are slightly different in certain beats. Here we see an atrial rate which is like 125. We have a ventricular rate which is 1, 2, 3, 4, 5, about 60, and it is variable. And we see some of the P waves are conducted to the QRS complexes. So this is not a first degree AV block. This is not Venki block. This is not second degree type 2 AV block. And do we have a high grade AV block? Possibly, yes. Is this complete heart block? It doesn't look like complete heart block. If it is complete heart block, we should see AV dissociation where none of the P waves are conducted to the ventricles. Here we have one rhythm where the QRS complexes are different, and here we have another type of QRS complexes which appears to be a fusion beat. So this is an example of a high grade AV block. This is how you try to arrive at a diagnosis by excluding the other choices in the multiple choice questions. Unless you think about each one of these choices, the chances of rushing to a quick answer can result in a wrong answer. Next, what is your diagnosis? Of course, this is a 12-lead electrocardiogram, and we have a narrow QRS complex, which is also variable, and we have multiple P waves with no conduction to the ventricles. There appears to be no change in the morphology of the QRS complexes. So we are dealing here with an example of a complete AV block. When we are talking about complete AV block, we have to understand that there is significant disease involving the AV node, and complete heart block is a much more serious problem than a first degree AV block or a Venki block. Next. Okay, here we have a slow rhythm. We got 8. So the heart rate is approximately 38, which is very slow. We have narrow QRS complex. So this is most likely a junctional rhythm. And let's look at the atrial activity. And here is a P wave, here is a P wave, here's 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 a P wave. So there are almost 2 P waves for each QRS complexes, but there is no relationship between the P waves and the QRS complexes. That means they are not conducted beats from the atrial level. So that means we have AV dissociation. So we have atrial rhythm along with AV dissociation with junctional escape rhythm. Along with that, we see some ST depression here with what looks like a biphasic T wave. When you look at these changes, when you have these ST changes which look like maybe a digitalis effect, you always think about what might be causing this kind of a rhythm. Is this digitalis toxicity leading to high-grade AV block? So whenever we are dealing with conduction disturbances, we need to look at correctable abnormalities such as myocardial ischemia, presence of electrolyte abnormalities, or drug toxicity, either digitalis or even antiarrhythmic drugs that affect the AB node. So this is an example of a complete heart block with junctional escape rhythm. Let's move on to the next slide. When you are dealing with, when you are presented with a patient who has a complete heart block, the treatment options are transcutaneous pacemaker or transvenous pacemaker, and most of these patients will end up needing a permanent pacemaker because there is AV dissociation and because there is underlying sinus rhythm. These patients will benefit from AV sequential pacemaker and optimizing the PR interval. When we started, I talked about the significance of a PR interval in optimizing cardiac output. So this is one example where putting a dual chamber pacemaker with optimal PR interval to maximize the cardiac output is of importance in improving patients' symptoms and quality of life. Let's move on to the next presentation. Okay, that concludes our presentation on conduction disturbances from the sinus node all the way up to the AV node. And now we're going to look at conduction disturbances below the bundle of His, which would involve the left bundle, then the right bundle, and also some intraventricular conduction delays, fascicular blocks, and we'll conclude with wide QRS complexes and a special mention of Brugada syndrome. I want to give you some important tips on the left bundle, which we are going to be talking about in a moment. The left bundle, unlike the right bundle, has multiple branches. It has a small septal branch right after it arises from the bundle of His, which activates the interventricular septum that produces the Q waves in lead 1, V5, and V6. It also produces a tiny R wave in V1 and V2. After that, the left bundle divides into the left anterior fascicle and the left posterior fascicle. The left anterior fascicle is the smaller one and it is in the septum, and it is one of the ones which is more often involved in conduction disturbances. The left posterior fascicle travels through the entire septum and supplies the lateral wall and a rich Purkinje network that occupies the entire left ventricular wall. So, if we have the septal involvement, we may not be able to diagnose the presence of anterior myocardial infarction. On the other hand, if we have a left bundle branch block which is involving the left anterior fascicle, we may have features of not only the left bundle branch block but also left anterior hemiblock, and we are going to look at some examples related to that. If the conduction disturbances are below the origin of the left anterior fascicle, we may have just a regular left bundle branch block without evidence of left axis deviation or left anterior hemiblock. The right bundle branch has only one main trunk that traverses the right ventricular wall and provides a rich network of Purkinje fibers which activates the entire right ventricle in one stroke. Okay, what is your diagnosis? More importantly, I'm interested in you writing down all the abnormalities you see in this electrocardiogram. In cardiology boards, when you are interpreting an electrocardiogram, you are not rewarded for just identifying the most obvious finding, but you are given points for every finding that is on this electrocardiogram that you can properly identify. I'll give you a moment, pause this video, write down all the findings. Better yet, take a copy of the cardiology EKG section coding sheet and write down all the points that relates to this particular tracing. In that way, you begin to get into the habit of recognizing everything that is abnormal. Okay, let us look at what we have here. First, let us describe what we are seeing. This is a sinus rhythm. Rate is approximately about 88 to 90. So this is a sinus rhythm. Along with that, we have a wide QRS complex, which appears to be like left bundle branch block, because we have wide QRS in lead 1, ABL, and V5 and V6. So the impulse is traveling through the myocardium here instead of through the left bundle. So the left bundle is involved in this conduction disturbance. So we have a wide QRS complex. Next, we also have left atrial enlargement. We also have ST elevation in the anterior leads, which is a common finding in patients with left bundle branch block. Also notice the deep S waves, which reflect the activation of the left side through the myocardial tissue. Next, we see there is ST depression and T wave inversion. These are discordant to the direction of the QRS complexes. This is an exceedingly important point that we have to mention when we are interpreting electrocardiograms in a setting of a cardiology boards. So we have ST depression and T wave inversions. These are the patterns related to the left bundle branch block. It doesn't signify any acute myocardial ischemia, and we also see there is some degree of left axis deviation. If you look at the positive and the negative deflections are almost equiphasic, and lead 3 and ABF are negative. So we are looking at minus 30 degrees left axis. Minus 30 degrees left axis is normal. However, if this is more than minus 45 degrees, then we would be talking about left anterior hemiblock also. If this is more than minus 45 degrees, then we would be talking about left anterior hemiblock and left axis deviation. However, this is not quite left anterior fascicular block. So in conclusion, we have sinus rhythm with the left axis deviation, not necessarily left anterior hemiblock. We have left atrial enlargement. We have left bundle branch block with discordant STT changes, and the ST elevations, which are a normal variant in patients with the left bundle branch block, does not signify myocardial ischemia or infarction. So if you go through this list, is this right bundle branch block? No. Is this left bundle branch block? Yes. Do we see a left anterior hemiblock? No. Is this acute anterior myocardial infarction because we are seeing 2 to 3 millimeter ST elevation? No. Is this ischemia? No. Is this intraventricular conduction delay? No, because the PR interval is greater than 120 milliseconds, so it is not intraventricular conduction delay. When you have a bundle branch block and the QRS interval is between 110 and 120 milliseconds, then it is supposed to be signifying incomplete left bundle branch block or incomplete right bundle branch block. And if we are not sure whether it is right or left bundle branch pattern, then we think about intraventricular conduction delay, which is a non-specific conduction disturbance, but nonetheless, it does signify underlying problems with the electrical system of the heart. Is this Brugada syndrome? No. We're going to learn more about Brugada syndrome later on in this presentation. Now, to summarize all the findings I talked about, here's a nice chart. First of all, complete left bundle branch block features include wide QRS complexes in lead 1, ABL, V5, and V6. The QRS duration in these patients are more often greater than 140 milliseconds. Then it is associated with discordant STT changes. This is an important finding. You have to mention it. There is a separate column in the cardiology board answer key. discordant STT changes, the anterior deep S waves, the peaked R waves in lateral chest leads. The R waves peak in the lateral chest leads after approximately 60 milliseconds. If you look at patients with normal electrocardiogram or patients with left ventricular hypertrophy, usually the R waves peak within the first 40 milliseconds. When you have slow peaking of the R waves in leads 1, AVL, V5, and V6, that is an indication that you're dealing with a left bundle branch block, unless you are also dealing with a pre-excitation, which is a totally different condition, and we will be covering that towards the end of this lecture. The notched R waves in the lateral chest leads may resemble like a M, as you can see here. Of course, we are seeing here, we may not be seeing in this particular tracing in the lateral chest leads. So always remember these findings, and when you see a constellation of all these findings, think about left bundle branch block. When you see left bundle branch block, you describe all the findings. Look for other conduction disturbances, such as first degree AV block or left anterior hemiblock, which will make this more significant. So instead of having a single left bundle branch block, you could be dealing with a bifascicular block or even a trifascicular block. You should always expect more than what is obvious on the electrocardiogram. Most of the time, the left bundle branch block is pathological. It is caused by significant underlying heart disease such as aortic stenosis or myocardial infarction, hypertension, or valvular heart disease, and sometimes brought on by cardiac surgery. Let's move on to the next slide. Okay, here what do we see? Basically, it's the same electrocardiogram from the previous slide, but I am trying to stress another important point. You have heard that we cannot diagnose myocardial infarction in the presence of a left bundle branch block, or if you see a patient with a chest pain and a new onset of a left bundle branch block that is synonymous with acute myocardial infarction, and so on and so on. But if you have a patient with an underlying left bundle branch block documented in the past who comes with acute chest pain, how do you diagnose the presence of a myocardial ischemia or infarction in the presence of a pre-existing left bundle branch block? Garbosa looked at a series of patients with left bundle branch block who presented with chest pain and elevated cardiac enzymes and who were proven to have coronary artery disease, acute ischemia, came up with these observations. Yes, indeed, we can diagnose acute myocardial ischemia or infarction in patients with complete left bundle branch block, provided we find some additional findings to support myocardial ischemia or infarction. What are those additional findings? In the previous slide, I talked to you about the discordant STT changes in the lateral leads. ST elevation in the anterior leads, which were all normal findings in a patient with left bundle branch block. However, if there is a deviation from these normal accompaniments of left bundle branch block, then that may be a signal that you could be dealing with myocardial ischemia or infarction based on the clinical presentation and cardiac markers. So let's look at, if you see ST elevation of greater than 1 millimeter in the same direction, that is concordant to the QRS complex, you give 5 points. So in other words, here we see STT changes which are discordant to the QRS complex. They are going in the opposite direction. Whereas if the same patient comes with chest pain and now you see ST elevation, then that is significant, suggesting myocardial ischemia or even myocardial infarction in the presence of left bundle branch block. Point number 2, I told you we generally see ST elevation in the anterior leads in patients with the left bundle branch block along with the deep QS complexes. Whereas In patients with acute chest pain with pre-existing left bundle branch block, if we see ST depression in these leads, it may be suggestive of myocardial ischemia or infarction, and that carries 3 points. Third point is ST elevation of greater than 5 millimeters in the opposite direction of the QRS complex, that gets 2 points. Garbosa also went on to say that you require 3 points to diagnose acute myocardial infarction in a patient with a pre-existing left bundle branch block. So there are at least 3 additional criteria that can be applied in patients with pre-existing left bundle branch block to diagnose myocardial ischemia or infarction based on the clinical presentation and also the elevation of cardiac markers. Okay, let us continue. Now we're going to switch gears and talk about right bundle branch block. In the previous slide, we saw changes involving primarily lead 1, AVL, V5, and V6. The right bundle branch, when it is blocked, the impulse travels through the left bundle, and from there it traverses through the myocardium to activate the right ventricles. So there is delayed activation of the right ventricle. Because the septal branch of the left bundle is not involved, we have normal initial activation of the right ventricle, which produces a tiny R wave. And then we have a deep S wave followed by a second wave that is coming through the myocardium, activating the right ventricle, resulting in a R, S, R prime morphology in V1 and a reverse of that in V6. One important distinction I want to bring to your attention is the S wave. One of the hallmarks of right bundle branch block is the slurred S wave in practically all the leads on the electrocardiogram. If you see slurred S wave in most of the leads on the electrocardiogram, you may be dealing with either a complete or an incomplete right bundle branch block. And we're going to look at a few examples of this. So let's continue. Let me pause here for a second. There are multiple findings in this electrocardiogram. Take your answer sheet and check all the findings that you see, and then we'll resume and see how many different points we can identify in one simple electrocardiogram on this screen. First of all, we have sinus rhythm. All right. One thing that is obvious is the presence of a right bundle branch block. As we saw from the previous slide, we have a QS complex, not RSR prime, but nonetheless we also have first degree AV block. So we have a first degree AV block, we have a right bundle branch blocks. So we already picked up 2 important findings. So we have bifascicular block. And the third point is we have loss of R wave in the anterior leads replaced by a Q wave. So we are talking about anterior myocardial infarction. Is this an acute anterior myocardial infarction? No, because the ST segments are almost to the baseline. So we are dealing with an old anterior myocardial infarction with right bundle branch block and first degree AV block. So we already have bifascicular block. What else do we see here? We also have some Q waves which are much deeper than they are waves in lead 2 and 3. So this patient may also have an old inferior myocardial infarction. Remember I talked about the slurred S waves? So look at these S waves. These are slurred here, they are slurred here, and again if you look at here, we'll look at some other examples where the S waves are slurred, and that's one of the hallmarks of right bundle branch block in leads other than V1 and V2. So here, if I were to summarize all the findings, we have sinus rhythm, first degree AV block, old anteroseptal myocardial infarction, right bundle branch block, old inferior myocardial infarction, and along with that, look at the T waves. These T waves are not normal. These T waves are flat to biphasic. So we have non-specific STT changes. As you can see, there's a lot we can deduct from just looking at one simple electrocardiogram, and that is how you approach these tracings. Not just what is the one main point. It is not like a multiple choice with is this right bundle branch block, is this left bundle branch block, because as a cardiology student, you need to point out every little detail that you see. So this is sinus rhythm with enteroseptal myocardial infarction, probably old, with right bundle branch block, first degree AV block, that is bifascicular block, also inferior old inferior myocardial infarction, non-specific STT changes. Enough for one electrocardiogram. Let's move on to the next tracing. Okay, what is your diagnosis here? As I said, write down all the findings that you can find in this tracing. There are quite a few abnormalities in this electrocardiogram, I can tell you right just looking at it. When you're ready, then proceed. Okay, let us start off. Whenever you see an electrocardiogram, you look at the whole picture, the global picture. Then you go from regions: anterior, lateral, enteroseptal, inferior. Okay, what do we see here? We got a sinus rhythm. The PR intervals are normal. Then we have a negative deflection in the inferior leads. That's the negative deflection is more than the positive deflection. So we are looking at the left axis deviation greater than 30 degrees. So this is between minus 30 and minus 90 degrees. So we are looking not only at the left axis deviation, we are also looking at the left anterior hemiblock. We also have a right bundle branch block, but the PR interval is normal. So we are already deducting we have a right bundle branch block and a left anterior hemiblock. So we are already dealing with the bifascicular block. What else do we see here? We have some non-specific T-wave changes in one AVL, and also in the inferior leads. So these are some of the findings in this patient. And always, when you see one finding, look for other findings, because misery always keeps company. Good. Let us move on to the next tracing. Okay, what is your diagnosis here? Ooh, this is much more interesting than what I thought at first glance. Okay, let me start off here. First of all, we see P waves. Whenever we see P waves, and when the QRS complexes are not marching along with the P waves, then you worry about high-grade AV block or maybe a complete heart block. So let's not jump to that right now. Let's start with the simple things. So here we have a P wave, here we have a P wave. There could be another P wave here, I don't know, we have to find out. There's another P, okay, so there are two P waves actually to each QRS complex. And there's no relationship between the P waves and the QRS complexes. The QRS complexes are almost similar in morphology. So there is AV dissociation. There is fast atrial rate, which is about 100. Then we have a right bundle branch block, along with what appears to be a complete heart block. And we also see discordant STT changes related to the right bundle branch block here, and the slurred S wave, which I talked to you, which is clearly visible in the lateral chest leads. So let us summarize some of the findings that are related to right bundle branch block. First, there is an RSR prime in V1, as we can see here. Sometimes we see right axis deviation, but in majority of the cases, we may not see right axis deviation. However, if we have a patient with the right atrial enlargement from pulmonary hypertension and other conditions, we may see right axis deviation. And I talked about the slurred terminal S waves seen in the anterolateral leads. Keep that in mind. Of course, a complete right bundle branch block will have a QRS complex of greater than 120 milliseconds, or at least 3 small boxes. It is also associated with the discordant STT changes. Generally, as I said, right bundle branch block does not cause a change in the electrical axis unless there is accompanying fascicular block, like left anterior fascicular block or even left posterior fascicular block. If you see a pattern of a right bundle branch block with a QRS duration of 110 to 120 milliseconds, then we are talking about incomplete right bundle branch block. Let's move on to the next tracing. Okay, what do we see here? Here we have a sinus rhythm. Again, left axis deviation, left anterior hemiblock, right bundle branch block, and non-specific STT changes. It looks like this. We already saw this tracing. Somebody is trying to trick us to see if we remember what we just talked about. Okay, let's move on to the next one. Okay, what do we see here? Here we see sinus rhythm. There are slurred S waves in 1, AVL, and also in the lateral chest leads. We have a right bundle branch block pattern, but however, the QRS interval is less than 120 milliseconds, so we are most likely dealing with incomplete right bundle branch block and some non-specific STT changes in the anterolateral leads. Okay, what do you see here? Here we see a negative deflection in lead 1 and a positive deflection in lead AVF. That means this is in the lower quadrant of the electrical axis, which suggests right axis deviation. So this is a patient with left posterior fascicular block. Other than that, we don't see any significant right bundle branch block or left bundle branch block features in this tracing. Left posterior fascicular block features include a QRS axis of plus 120 degrees, which is right axis deviation. The QRS width is less than 120 milliseconds. As we can see here, there is no prolongation of the QRS interval. We see an RS pattern in 1 and AVL. This is what we are seeing, a small R and a deep S wave in lead 1 and AVL. Then we see a QR pattern in leads 2, 3, and AVF. When we are looking at this, we need to consider right ventricular hypertrophy, pulmonary embolus, chronic obstructive pulmonary disease, or lateral myocardial infarction. Let's move on to the next tracing. What do we see here? Well, we have a sinus rhythm. There's more negative deflection in lead 2 with negative deflections in 3 and AVF. So we are dealing with left axis deviation. The right and the left bundles look okay. There are some non-specific STT changes in 1 and AVL. The T waves look normal in the inferior and the anterolateral leads. So we have a case of a left axis deviation, left anterior hemiblock, non-specific STT changes in the high anterior or the high lateral leads. Other than that, I don't see anything significant. Do you? Let's move on to the next tracing. Okay, now we are going to switch gears and look at a rare condition. Is this right bundle branch block? Is this left bundle branch block? So we are looking at V1. Of course, there is some evidence of left atrial enlargement, and then we have the initial R wave followed by a deep S wave. Now we have elevation of the J point with a downsloping ST segment which blends into the T wave. This is characteristic finding that we associate with Brugada syndrome, which is a condition which leads to right ventricular outflow tract pathology associated with ventricular arrhythmias. And we're going to look at some examples of this condition. Okay, here is a tracing. Just take a moment, pause the video, and write down all the findings. That is the only way we are going to learn to meticulously document all the abnormalities so that we can put all the pieces of this puzzle together and come up with a composite diagnosis. When you are writing a cardiology EKG section, all the findings are more important than the composite diagnosis because they want to make sure that you identify every little abnormality on the electrocardiogram. So here we are seeing a sinus rhythm. Then we have a weird pattern which I showed you in the previous slide with J point elevation with a convex ST segment blending into the T waves, and this is a case of a Brugada syndrome. There are various types of presentations in patients with Brugada syndrome, which we're going to look at, and also look at there are some non-specific STT changes in lead 1, ABL, and also the lateral chest leads. There's some ST depression here. There's also some variation in the rhythm, which may be sinus arrhythmia. Other than here also we see variation in the RR interval, but it is sinus rhythm because we have regular PQRS relationship. So this is a sinus arrhythmia with Brugada syndrome with non-specific STT changes. So let's get a little deeper into looking at the various types of Brugada presentations. There are three types, namely type 1, type 2, and type 3. So let's see. We talked about J point elevation, which is one of the hallmarks of Brugada syndrome. We can see 2 millimeter elevation in J point in all these three types of Brugada syndrome. Now let's look at the ST segment. The ST segment can be curved as we see in type 1, or the ST segment could be looking like a saddle in type 2, and similarly in type 3 it may also look like a saddle. Now let's look at the morphology of the ST segment. So the ST segment, we see a gradual slope here. We see an ST segment elevation with what appears to be like a biphasic T wave, and similarly in type 3 the ST segment has sort of a biphasic appearance blending with the T wave. In type 1, the T waves are inverted, they are below the baseline, whereas in type 2, the T waves are lifted from the baseline even though they are inverted. Similarly in type 3. So these are minor variations in patients with the Brugada syndrome. Most important thing is to identify this Brugada syndrome and look for other features of Brugada syndrome by doing echocardiography and other tests to make sure these patients are appropriately managed based on this electrocardiographic findings. Now, I would like you to take a moment and write down all the findings that you see in this electrocardiogram. This is one of the most deceiving electrocardiographic findings in the entire EKG interpretation book. This is like something that can mimic anything in cardiology EKG findings. So take a moment, then when you are done, let us resume. First of all, we have a bradycardia. The rate is slow. And we see some P waves here, and there's a constant relationship between the P waves and the QRS complexes. So we are dealing with the sinus bradycardia. One of the obvious findings in this is the presence of delta waves here. The delta waves with a short PR interval, we are dealing with Wolff-Parkinson-White syndrome with the accessory pathways in the left atrial wall that is resulting in pre-excitation and then later activation of the normal QRS through the normal conduction system through the AB node and the bundle branches. But there are a lot of other findings in this electrocardiogram besides the delta waves and slurred R waves. There are T wave changes here which are abnormal. And we also see QS complexes in the inferior leads. We also see, so these are abnormal findings. Do these represent myocardial ischemia or infarction? WPW or the Wolff-Parkinson-White is one that can create pseudo-infarction in the inferior leads or the anterior leads. It can create an image of ventricular hypertrophy, right ventricular hypertrophy based on the direction of the QRS complexes. That's why I said this electrocardiogram is one of the most deceiving ones because it mimics so many other conditions besides just having a delta wave. Let's look at the next tracing. As I was saying, this delta wave is caused by the accessory pathway in the left atrial wall. In patients with WPW, the impulse traverses from the sinus node to the AV node and also to the accessory pathway. If the accessory pathway has a fast transmission feature, then it produces a delta wave where the impulse coming from the AV node catches up and then produces the sharp R waves which are blended. So it is basically a fusion beat between the AV nodal conduction and the conduction through the accessory pathway. Next. Here's an example of another patient with WPW. But look at the R waves here. They are so tall in the anterior leads. So depending upon the direction of the R waves, which are basically related to the direction in which the impulse is traveling based on the location of the accessory pathways, WPW has been grouped into two types, namely type A, which is the anterior type, and group B, which is the inferior type. We're going to look at some examples of those. So this is type A WPW, where we see tall R waves in the anterior leads along with the short PR interval delta waves. And so this is an example of type A WPW. It may signal right ventricular hypertrophy, which is usually not the case, and you can also see some discordant STT changes in the same leads. Let's look at the next tracing. And here's a tracing with a patient with a WPW. Now the QRS complexes are negative in V1 and they are also negative in 3 and AVF. So this is an example of type B WPW. WPW is a mysterious condition. Majority of these patients don't even know they have WPW until they go for a routine examination and their electrocardiogram shows WPW. As they get older, they develop various kinds of arrhythmias, and the most important of which are irregular supraventricular tachycardias. And in those conditions, the rates can reach up to 300 beats per minute. That's why symptomatic WPW is a real challenge to deal with medications. Talking about medications, so here are choices: amiodarone, beta blockers, calcium channel blockers, digoxin. Which drug would you use to treat these patients? Take a moment, write down your answer, and we will continue. And we'll continue after that. In order to understand which drug works best for patients with WPW, we need to go back to the previous slide where we had the conduction system picture. And here we have conduction through the AV node and conduction through the accessory pathway. In most cases, the conduction through the accessory pathway is a fast channel, so we see rapid wide QRS tachycardia. We can see narrow QRS tachycardia going through the AV node, but more often in patients with WPW, we see wide QRS tachycardia with variable ventricular response as high as 300 beats per minute, and that is due to the conduction through the accessory pathway. But if you go back to our choices here, all these drugs, amiodarone, beta blockers, calcium channel blockers, and digoxin, all these act on the AV node. And when all these act on the AV node, what's going to happen? They're going to block the AV node, and the impulse through the accessory pathway gets uninterrupted. As a result, now you can get a much faster rate, and hence these drugs are not the first line of defense. In fact, some of these drugs can make the arrhythmias in WPW worse. The only drug that affects the accessory pathway conduction is procainamide, which can be given intravenously or orally depending upon the urgency. So here is an important tip I want to give you. If you see a question like this in board examinations, always remember WPW, no ABCD. No amiodarone, no beta blocker, no calcium channel blocker, no digoxin. A, B, C, D. No. WPW, no A, B, C, D. The treatment of choice is procainamide, cardioversion, or EP studies and ablation of the accessory pathway. Let's move on to the next one. There's one more tracing which I want to touch upon, and that is the short PR interval, which is seen in patients with the LGL syndrome. And basically, we have a short PR interval where the rest of the electrocardiogram looks pretty much normal. So let's move on to the next slide. So ladies and gentlemen, that brings us to the end on chapters Conduction Disturbances and Bundle Branch Blocks. We have been talking about EKG interpretation, which is an accompaniment to my clinical EKG interpretation and patient management book. It is an electrocardiographic book which you can check on Amazon.com. And please do watch our first presentation on introduction and electrical axis. And in the next presentation, we will be covering sinus node dysfunction and bradycardias. Thank you so much for watching this presentation, and please do subscribe to our YouTube channel. Have a wonderful day.